Hello and welcome to the Cytokine Signalling Forum Author Interview Podcast. My name is Professor Peter Nash from the University of Queensland, and today I have the pleasure to talk with Professor Roy Fleischmann from the University of Texas Southwestern Medical Center. Welcome, Professor Fleischmann, and thank you so much for your time today.
Thank you.
So today we're here in New York, where upadacitinib has recently been approved by the FDA, and there's a launch meeting going on. And we'll be discussing two papers, very topical, on upadacitinib that have recently been published. The first is the UPA versus placebo or adalimumab in patients with rheumatoid arthritis that have an inadequate response to methotrexate, results of the phase 3 double-blind randomized controlled trial. The second is the safety and efficacy of UPA or adalimumab plus methotrexate in patients with RA over 48 weeks with switched therapy in patients with insufficient response. So let's start off by talking about upadacitinib for those people who aren't familiar with the drug. Can you tell us a little bit about this particular JAK, please?
So upadacitinib is supposedly a JAK1 preferential molecule, oral small molecule.
So it's selective JAK1, it's an oral small molecule, and it's a once-a-day dosing extended-release medication, okay? This select pair paper would be one of the pivotal papers of this last 12 months. Can you tell us a little bit about the design and how you went about this particular study?
So this is a very unique study. I think actually it was probably the first study that was designed in this way. So what we did was in the primary endpoint was an ACR20 at week 12 of upadacitinib 15 milligrams, not 30 milligrams, but 15 milligrams, which is now the approved dose in the U.S., plus methotrexate. In methotrexate incomplete responders, patients who continued methotrexate and then treated with placebo. And as I said, the primary endpoint was an ACR20 at week 12 for the U.S. For the EMA, the primary endpoint was achieving a DOS-28 CRP of less than 2.6. Both of those points were met versus placebo. In the initial part of the study, although there was a group that was on adalimumab, methotrexate in methotrexate incomplete responders, that was not the primary endpoint of the first part of the study. That was actually a ranked secondary endpoint. So the ranked secondary endpoint was comparing upadacitinib 15 milligrams plus methotrexate to adalimumab plus methotrexate by an ACR 50 at week 12. And also what was ranked was a change in the HAC, upadacitinib versus adalimumab, and changing facet F of upadacitinib versus adalimumab. So what was unique about this was that you have the initial part, which is, does upadacitinib work versus methotrexate? Yes. And then a powered head-to-head of upadacitinib versus adalimumab using the ACR 50, which is the appropriate endpoint in this type of study because it's head-to-head. And looking at both the ACR 50 and the HAC, but now for the first time the facet F as well. And then the second part of the study, this is week 20, this is 26 weeks, is that the patients who did not have an improvement of at least 20% in tender and swollen joints, who were treated with adalimumab, was switched to upadacitinib. Patients who did not have that type of response, who were on the reverse, adalimumab switched to upadacitinib switched to adalimumab, and placebo was switched to upadacitinib. So this is now the first study of a patient who fails a TNF, fails adalimumab, and is switched to a JAK. We have a number of studies of patients who failed the TNF and switch to JAK, but we don't have the reverse.
Okay, so
we looked at that.
That's unique and very nicely done. So just tell us a touch about the baseline demographics about this group of patients. They were long-standing rheumatoid with a pretty active disease.
Yeah, so it was a basically female population in the mid-50s, active disease about 8 years, as I remember. They were on methotrexate, a fair dose of methotrexate. I think the mean was about 17 milligrams. And they had active disease. If you looked at the C-dial, looked at the DOS-28 CRP, and the joint patient global, physician global, et cetera, high HAC. Almost all of them were positive for rheumatoid factor or anti-CCP. And we also looked at X-ray in this study. And the mean total sharp score, modified sharp score, at baseline was in the mid-30s. So they had active obstructive disease.
And can you just tell us about the primary endpoint and what were the results of the study?
So the primary endpoint was, is upadacitinib plus methotrexate superior to placebo plus methotrexate based on an ACR20 at week 12? Yes. And did it achieve a DOS-28 CRP of less than 2.6 versus placebo at week 12? Yes, it did. That's the primary point. The ranked secondary was, which is very important, was this head-to-head of upadacitinib versus adalimumab. And upadacitinib was superior in terms of obtaining a ACR50 and in terms of a HAC response, a better HAC response with upadacitinib than adalimumab, and in improving fatigue. So the three ranked secondary endpoints of upadacitinib versus adalimumab were also positive.
So what's the standard therapy of TNF and methotrexate in many countries in the world for the second, the JAKs have shown that they can be superior to that gold standard as long as there's a combination of methotrexate.
Well, as you know, there were actually 4 different studies,
yes. Right?
So there are 2 studies, this one with upadacitinib, the one with baricitinib at 4 milligrams, where there was we also did the study of tofacitinib versus adalimumab, where the endpoint was a little bit different. It's a little bit different.
Study design.
Different study design, where that was at least as good as adalimumab. Then we also saw a report, it hasn't been published yet, of filgotinib versus adalimumab, where the higher dose of filgotinib, the 200 milligrams plus methotrexate, in terms of a DOS-28 CRP, less than 3.2, was superior to adalimumab as well.
So it's building the strength of the whole JAK class in comparison to the TNF. It makes it feel more consistent and more across the board, if you like, as long as there's methotrexate in the mix, I suspect.
So all these studies were in combination with methotrexate. Yes. They were not monotherapy. Yes. As you know, one of the major advantages of JAKs is that many patients can be treated with monotherapy. But monotherapy has not been shown to be superior. I think that there has been a paradigm shift. There will be a paradigm shift in the near future, depending on economics.
Sure.
Because everything's economics,
sure.
Right? If these drugs are affordable compared to biosimilars, and remember that one of them, tofacitinib, will be generic in not that many years, there is evidence that you probably could, and maybe you should, use a member of the JAK class before a biologic after methotrexate failure. You can certainly consider that.
Sure.
And you also have to think about safety.
Right? We'll come to safety. Now, just to talk for a second, different speed of onset of action of the JAK and the durability over time. How long would you treat for before you would say this person is a non-responder?
So what we saw in this study, which we've also seen with baricitinib, we've also seen with tofacitinib, and I think we've seen with as well, is that patients can respond and separate, actually, from adalimumab within a week or 2. So they have a very quick onset of action, which isn't surprising considering that they're very short half-life. They reach steady state very quickly versus a biologic. What we've also seen with all of these drugs, including this one in this study, is maintenance of response. You don't see tachyphylaxis. So the responses that we've seen up to a year, 48, have been maintained, and the separation between upadacitinib and adalimumab has also been maintained for the 48 weeks.
And is there, with TNFs, you can make your call at 12 weeks to decide that they've usually plateaued at about that time, stop, go with the therapy. What about the JAKs?
I think that that's the same. So what I would do, so we could have a discussion here, but the JAKs certainly can work quicker. What I tell a patient is, you may have a response within a week. I want to look at you in 12 weeks. In 12 weeks, you could have a response. You may not reach goal in 12 weeks, but you may have had a pretty good response. Had a good enough response, a drop in the C9, 50, 60%. And then they start with high disease activity. Now they're in moderate disease activity. Not low disease activity, but they drop from high to moderate. I might consider them for another 12 weeks before I give up. I would actually do the same thing with biologics.
Sure.
If a patient responds but doesn't get to low disease activity, but they're responding, I'd give it another 12 weeks.
Okay, now dissect a little bit of this ACR responses, because Baricitinib has made a big deal about the pain separation from the TNFs. See that kind of separation in this UPA study. For example, did the swollen joint count separate? Did the pain separate? Physician, for Barry, it was pain, physician, and patient global that seemed to drive the superiority. What about with upadacitinib?
Exactly the same.
Exactly the same. So it's not swollen joints, but it is those other parameters.
I don't remember, but swollen joints dropped, tendon joints dropped, pain dropped, fatigue dropped, physician global dropped, patient global dropped. They all dropped. They all.
But I think there's no separation in the drop of swollen joints, TNF to UPA, which is a very interesting difference.
Yeah, I'm not quite sure about that.
Okay. And can you speculate about this pain story? And JAKs, is there a peripheral nerve element? They don't seem to cross the blood-brain barrier.
They don't cross the blood-brain barrier. No. We also know that IL-6 is involved in peripheral nociception. And the JAKs do inhibit, to some extent, IL-6. So it may be in inhibition of IL-6 that you're seeing this differential response, but there may be other factors as well. We've shown with baricitinib, I suspect we could show the same with upadacitinib with tofacitinib, that the difference in pain is not just inflammatory. So you get a significant drop in pain even in patients who don't have a significant drop in CRP. With adalimumab, the drop in pain is due to inflammation.
And that's very curious, because Gilshed has shown MRI brain changes with TNFs before swollen joints drop, SAR drop. So there's it's a complicated issue. And I think
when did you show that?
Yeah.
When?
Oh, last year, I think. We could find the reference, but it's interesting.
Because the initial, you're old enough to remember, when infliximab was out there, when it started, so this is 1999, we saw patients treated with infliximab who had tremendous pain relief within an hour or two.
Sure.
Before they have inflammatory. So we knew there was a central effect of that TNF 20 years ago.
And that's interesting because, again, large molecules not supposed to get across the blood-brain barrier, so I'm not sure I understand that. Tell us a little about the radiology side of this particular study.
Yeah, so the drug does not stop radiographic progression, but it certainly inhibits radiographic progression. So what we saw in this study was it was about 88% of patients did not have progression, as opposed to the methotrexate group, where it was about 78%. So we're used to that with methotrexate. It's about 75, 78%. So there are more patients who do not have progression. The degree of progression is lower with the upadacitinib than it is with methotrexate. But of course, if you did a probability plot, you'll see one or two patients who will progress no matter what.
True DMARD, okay.
It's not an NSAID. Although it's oral, it's not an NSAID.
Now, safety, there are a lot of safety concerns with class. A little bit about safety issues and in particular topic issues like VTE.
Yeah, so let's talk about VTE because I don't know the answer to VTE. I do know that VTE, the VTEs that we see with this is not JAK2. I know it's not JAK2 because if you heard the whole discussion of the FDA, baricitinib, the FDA hematologist felt it was not JAK2, and there's no reason to suspect it actually. So what's interesting in compare, the study that we're talking about, there was a VTE in the placebo group. There were 2 VTEs in the upadacitinib 15 milligram group, and there were 3 in the adalimumab group.
It's quite balanced across them.
What's the balance? It was 1 to 2 to 3. So it depends on how you look at it. I look at it a little bit different. I think that's really what you were saying. You saw VTEs in every group.
Yes.
You see VTEs in patients who have RA, where they can treat treated with conventional synthetic, with a biologic, or with a JAK. Are the JAKs really more likely to produce a VTE than a biologic? I'm not sure that's true. I'm just not sure that's true. Is there dose related? Maybe. Maybe TOFA, but we don't know. But what we do know that in all the programs, the VTE risk is, the IR is about 0.5. And if you take a look worldwide, the risk of VTE not treated with any of these drugs is 0.5. So they do occur, so you have to be aware.
And your recommendation for the practicing clinician?
With the VTE? So the VTEs have been seen primarily in patients with past history VTE or a patient treated with a COX-2. So if the patient is treated with a COX-2, I would actually take them off a COX-2. I don't care if they're on methotrexate or adalimumab or if they're on upadacitinib, but I would not use a COX-2. And if they have had prior VTE, then my choice is, do I treat them with what or not? And the answer is, yes, I'll treat them with what? And what could be any of these drugs. But if they had a past history, I might think about prophylaxis of those patients, or certainly discuss the risk with them. But the risk of RA is terrible.
Yes. So with some VTE, the zoster, just some of those other infective type issues.
So zoster, occurs in patients with RA anyway, whether they're treated with these drugs. They do have a higher incidence than JAKs, with JAKs a little bit higher. What I tell the patients is you do have a risk. It is a little bit higher. I am now suggesting, that's available in the U.S., is Shingrix. But we don't really have the evidence yet that Shingrix is really safe and that it really prevents zoster.
Could you just tell us how you do that? You've got someone with active disease, methotrexate isn't working, you're about to go biological JAK. Do you stop things? Do you just give them a script for Shingrix? What do you do?
Shingrix is dead vaccine. I can do it anytime I want to. I don't have to do anything. Okay. Zostavax, which is live, I'm not sure it works real well, but there's a lot of evidence, registry evidence, that even Zostavax, you don't have to stop the drugs. Okay. Even though in all of the product inserts, it says stop the drug for 2 weeks, 4 weeks, 8 weeks, whatever. So I'm not sure that that's actually valid, that you really do have to stop the live vaccines. But we do prefer the Shingrix anyway.
Kevin Winthrop's publication suggested that if you got rid of steroids, then you could really reduce the zoster risk back to ground risk. That is to be done with UPA?
That analysis has not been done with UPA. I will tell you that I'm very well aware of the Winthrop and steroids with upadacitinib. We talked about that. Yeah. Might not. With baricitinib, we actually didn't see that.
Yes, it was unusual.
It was, we didn't see it. So with baricitinib, I don't know whether it's a difference in the molecule, but we've waited now. We've had lots of patients for a long period of time, and if that steroid risk is there, we should see it.
Okay.
The data actually came out with you less likelihood of a disaster with a higher dose.
That makes no sense at all.
Well, it may be correct.
What about TB? How should you handle TB with this drug?
So you would screen for TB before you start. And the product insert in the United States, which I agree with, is you would check periodically. Now, you and I have had this discussion. How good is the checking, right? So whether you do a TST or whether you do an IGRA, the physician has to realize that both of those are about the same in terms of their probability of being correct. It's about 80%.
Okay.
So you can't be 100% sure when you get a negative.
Right.
You can't be 100% sure. But you should check from time to time. And there are other places where, they just wait and see whether the patient's really at risk. Right? So I, with my patient population in Dallas, will tell a patient, if you're on these drugs or biologic, a good place to go might be Europe. And I don't know that I would go to South America or I would go to India or...
Very fine. Okay, so we've talked a little about that. Screening, this should be exactly the same as any other JAK, any other biologic. There's nothing special.
You check for the viruses, check hepatitis B, hepatitis C, HIV, you look for liver function tests. I do check lipids before I start, because the lipids are up, I should be treating it anyway, but I certainly check the lipids after I start. I want to make sure that the white count, particularly lymphocyte count, is high enough. I want to make sure that there isn't a marked anemia, because these drugs can cause anemia. Liver function tests.
So the usual JAK things, gastric, CP, creatinine, those kinds of things are seen with the, like every other JAK.
Okay, so you brought up an interesting problem. So you do see CP. There hasn't been a patient in this program that I'm aware of. There certainly hasn't been a patient in the Berry program or the TOFA program of a developed myositis, even though the CPK is elevated, and that's actually not a reason to stop it. And I've had patients who have persistently high CPKs, but they're doing well on the drugs, and I just ignore it. The increase in creatinine can occur, but again, there hasn't been a single patient who has had renal failure associated with any of these drugs.
Sure.
So I don't really worry about that either. And then what was the other one?
Gastric perforation.
So with UPA, it was interesting. So they do present, I think it's 3 cases of gastric perforation in their product. But when you actually take a look at them, they were not gastric perforations, right? There was an appendicitis, as I remember. There was
Anal abscess.
And anal abscess. Something else. So we don't really see the perforations. And I can tell you that in the Cerullimab data, there's actually very little perforations as well. So I think it's because we've come to realize that patients with a history of diverticulitis are not really the type of patient that would want to treat with an IL-6 or a JAK. So those patients are avoided. Okay. True diverticulitis.
Okay. Talk about the switch study now, because that's a bit unique to go from UPA to TNF. Can you tell us a little bit about how that part was put together?
Yeah.
Just remind us, and then what you found.
So what we did was in the first part of the study, the first 26 weeks, we looked at week 14 and 22. If a patient did not have improvement in tender and swollen joint counts of at least 20%, both of them, then they were switched. ADA went to UPA, UPA to ADA, placebo went to UPA. That was week 14, 18, and 22. At week 26, placebo patients were switched to UPA. Also, and very uniquely, any patient treated with UPA or any patient with adalimumab who didn't achieve low disease activity by CDAI, so a CDAI less than or equal to 10, true treat to target program. Those patients were switched as well. UPA to ADA, ADA to UPA. Right? So we had truly primary non-responders to a JAK, switched to a TNF, that's never been reported before, and a true primary TNF failure, switched to a JAK, right? The reverse. And what we found was, and the way to interpret this correctly, is that both groups responded. So there were patients who didn't respond to the JAK, did respond to the TNF. Patients didn't respond to the TNF, did respond to the JAK. If you look at the numbers, it looks like UPA is better than ADA, but I can say it's not powered. It's too few patients to really know. It may be true, but I wouldn't go to say that one is better than the other in the switch. But what is unique is I know I can switch. Very importantly, we did the switch immediately. So a patient who's on UPA and they come in week 26 and they have a CDI of 11, they're given Humira that day. They're given adalimumab that day.
Right.
No washout. Patient who's at week 6 who is giving adalimumab, but then they don't have a CDI, they are switched to UPA 2 weeks later. Okay. But you have to remember they come in week 26. That's when you do it. They receive their adalimumab 2 weeks later, 2 weeks before. So it was an immediate switch.
No washout.
No washout.
Is there a safety penalty for the immediate switch?
Was there a safety signal?
Yes.
Yeah. So as you would expect, because you'd expect that now you have both drugs on board, there should be a significant increase in certainly serious infectious episodes. Except we didn't see any of that. We didn't see any difference in the safety from immediately after the switch. So in the first 3 months after the switch to the 6 months after the switch, the first few weeks after the switch, then we saw it in the beginning of the study. We didn't see any safety signal.
Take-home message for the practicing clinician in that situation of having a TNF that's not working or even having a JAK that's not working?
So the take-home message is what the practicing rheumatologist has done for years now. You have a patient who you have on biologic, they're not responding, you decide you're going to make the switch, and what virtually every rheumatologist in the world does, virtually everyone, is they do an immediate switch now. It's different than clinical studies. And it looks like it's been safe. We've all thought it's been safe. This actually is data which shows you that it probably is safe.
So that's very reassuring. So these two important studies, I think certainly SELECT COMPARE is a very pivotal study. Any final take-home messages you want for the practicing clinician about upadacitinib itself?
With upadacitinib, so I think that upadacitinib, the program has shown it's better than methotrexate. So in the best of all worlds, where price isn't an issue, you might want to start with a JAK. You might want to start with upadacitinib. But practically, you're not going to do it. First of all, it's not in the label.
Yeah.
Secondly, the cost is prohibitive. Thirdly, we all love methotrexate.
Sure.
So you would start with methotrexate. But after methotrexate, what would you do? I am beginning to believe, and beginning to do, actually, that before I start a biologic, if I have access, I start a JAK. And the reason for that is what we've discussed before. You have 3 drugs which have shown to some extent that they're superior, the other is at least non-inferior. Why not start with the drug? Even though the numbers are small, the differences are small, why not use that type of drug? And then the argument is, if I've used TNF for 20 years, well, we've used JAKs for 7, 8 years, right? What's the difference? So I would use it early. And I wouldn't, now with this program, I actually wouldn't worry about starting a JAK if the patient has a response switching to a TNF,
okay,
switching to another mechanism.
Would you start?
Always start combo.
And reassess it a certain length of time, 12 weeks or something like that?
Yes. So I've shown with tofacitinib, I've shown with baricitinib, actually. I suspect we'll see the same thing with upadacitinib, although it hasn't been tested, or when they test that there are more patients that respond to the combination than to the monotherapy. Monotherapies work quite well. So usually what I would do is I would start methotrexate, and if the patient doesn't have a response to it has no response to methotrexate, which is rare, after 3 months, I would switch. I wouldn't continue methotrexate, I would switch to upadacitinib, tofacitinib, baricitinib as monotherapy. But if they have had a response, but not a good enough response, then I would add. And then when they have a good response, they achieve a remission, CNI remission, an SDI remission, then I would certainly consider reduction and possible elimination of the methotrexate. And I think that what I find in my practice, we've actually seen in studies, it's about 60–70% of patients can be treated with monotherapy of the JAK. And so when you think about monotherapy, you think about a JAK, think about an IL-6. But all of them, in groups of patients, will work better as combo.
Right. And I think in mature markets that have been using JAKs for many years now, it's really a question of persistence and adherence and keeping people on. Do you think they'll ever do head-to-heads with JAKs? And do you foresee a JAK IR study in the crystal ball future?
I think we'll see a JAK IR study. I'm sure we'll see a JAK IR study. It may be with new or different molecules, but I think we'll see a JAK IR study. The question is, what is Gilead going to do with filgotinib? Are they going to do something different now? I don't know. I do know that we are seeing studies with new mechanisms comparing to JAKs, right?
TYK2 inhibitors and the like.
BTK. We're seeing combination studies. We're seeing and the head-to-head rather than being adalimumab, being a JAK. Right? So we're shifting what we're seeing in terms of studies.
I'm sure that the clinician out there with the ability to prescribe 3 and soon 4 JAKs, how do they know which one to use?
You don't. So the issue is going to be, it's going to be marketing by the companies. That's clear. It's going to be access, which is cheapest. I think that we haven't seen all the data from filgotinib yet, but the data that we've seen, it seems to work fairly well. Whether it works as well as upadacitinib, I don't know because I haven't seen it head-to-head. Is it a little bit safer? There is a flavor that it may be a little bit safer, less zoster. I don't know about VTEs. So we may turn around and say that filgotinib possibly is a safer JAK, maybe not as effective, maybe as effective and safer. Right? We don't know.
Yes.
But clearly filgotinib is going to need something. Upadacitinib is coming to the market, at least in the U.S., where baricitinib is hampered because you only have the 2 milligrams, and its indication is after TNF. Against TOFA, some of its TOFA data is very strong, and TOFA is a very some of the data with upadacitinib is a little bit better. So how is AbbVie going to market versus Pfizer? Which would you pick? I don't know which one you would pick. I think it would be access.
Yes.
And you have baricitinib in Australia. Yes. Now, which would you pick?
Well, it's been very successful in Australia, baricitinib, very successful in Germany and many countries around the world. So I think it's going to be difficult for the clinician, and I think the question always, which should I pick to use?
But if they're really good, yes. So you make a mistake and you pick the other one that's really good, it's not so bad for the patient.
Exactly. And safety, I think, is really going to take registries and big numbers and comorbidities to show any difference between them. I think from clinical trials, it's going to be very tough.
But we're going to have to. But you have to be careful. I agree with you that it's going to be registry, but the registries have to be careful.
Sure.
They have to make sure that there isn't bias, so you don't get what we did with abatacept, which showed safety in registries because all the really bad patients were put on ABA.
Fair enough. So the nice control group and no selection bias in the registries. Okay. So we thank you very much for your time today. I think it's an exciting time to be a rheumatologist. I think we have seen a shift. This has been the CSF August Author Podcast. If you'd like to know more about this paper and others uploaded to the website this month with slides that are being worked on, they're available in the publication section at cytokinesignaling.com, cytokinesignall. Please subscribe to this podcast on iTunes or other podcast media and let us know what you think. We like to see some feedback. Thank you very much for your time, Professor Roy.
You're welcome.